Hello everyone, my name is Chamnanni Rungprai from Department of Orthopedics, Prat Mongkutgao Hospital and College of Medicine, Bangkok, Thailand. My topic today is posterior ankle arthroscopy, access, approach, and applications. Here's my disclosure. Posterior ankle pathology is challenging to diagnose and treatment because the posterior structure of the ankle located deeply from the skin. The standard open posteromedial or posterolateral approaches are commonly used. However, there is a risk of neurovascular structure and also wound complications. In 2000, Van Dijs and his team report a technique of posterior ankle arthroscopy. Since 1995, he has performed 86 consecutive endoscopic high foot procedures with no complications, and they believe the high foot endoscopy is a safe and reliable method for diagnosing and treating a variety of posterior ankle problems. Arthroscopic technique had gained increasing popularity in the past decade due to minimal damage to the soft tissue compared to standard open techniques, and this technique is claimed to be better cosmesis and faster recovery time. I would like to present the anatomy of the posterior ankle. As we were a medical students, we usually have the formula to help to remember the structure on the posterior part of the ankle from medial to lateral. We start with the thumb. It means represent to tibialis posterior tendons. It's right here. Disc mean flexor digitorum longus, and vari mean vein and artery. And nervous, it means tibial nerve, the yellow one. And hairy mean flexor hallucis longus tendons. FHL tendon is the important structure for the posterior ankle arthroscopy because it will be the most medial structure that you should not go beyond the FHL tendons in order to prevent injury to the neurovascular structure on the topo or axial anatomy of the ankle level. I will start with the Achilles tendons, which is located right here. Usually we mark both end of Achilles tendon to create a portal. And the next structure is of FHL tendon, which is usually seen right here, right next to the neurovascular bundle. And the last one is neurovascular bundle. So if you perform the procedure and you not go further medial to the FHL tendon, you should be safe and not injury to the neurovascular structure right here. The instrument for the posterior ankle arthroscopy, I use 4mm 30 degrees arthroscope, 3 or 4mm shaver, 3mm barrel burr, underwater cautery, and straight hemostat. For patient positioning, patient always pressed in a prone position with a thigh tourniquet. The ankle usually hanging slight over the edges of the bed, as shown on the right-hand side picture. For the surface anatomy, I always prefer draw a surface anatomy to help remind the important structure and avoid injury to the neurovascular structure. The structure from medial to the lateral begin with medial malleolus, neurovascular structure, medial border of Achilles tendons, lateral border of Achilles tendons, sural nerve pad, and distal fibula. An approach for the posterior ankle pathology, we usually use a standard posterolateral and posteromedial portals. However, if you perform a subtalar arthrodesis, accessory posterolateral portal is important. So the first portal is a posterolateral portal. We palpate the distal fibula and then we locate the tip of the fibula. And then we palpate the lateral border of the Achilles tendons and we draw the yellow line. And then we connect the line or make a dot from the tip of the fibula to the lateral border of the Achilles tendons. So the posterolateral portal is supposed to be just lateral to the lateral border of the Achilles tendons, as shown on the right-hand side picture. The next portal is posteromedial portal. We palpate the medial border of Achilles tendons, and the portal should be at the same level of the posterolateral portal and just medial to a medial border of Achilles tendons. And how to create a portal? Usually we make an incision only the skin, approximately 6 to 8 millimeter, and we use a hemostat. We use the technique we call nip and spread techniques, and the hemostat should make approximately 30 degrees towards vertical line, and then you go and try to create a space from the skin deep to the posterior part of the talus, and you do the same thing on the other portal. And don't forget to do a triangulations. So this will help you to find the camera during the procedure. I usually start the triangulation with the hemostat, as shown on the right hand side of the video. For the direction of the procedure, as you know, the medial side, they have neurovascular structure. So when you start performing the procedure, you have to make sure that you work toward the third toe or the fourth toe. More lateral is more safer than the medial. So take a look at the structure at risk again. This shows you how to do triangulations. Usually you touching your chamfer on the shaft of the camera and you slide distally until the tip of the chamfer goes further the distal part of the camera, so then you can see the chamfer. And when you start eating, keep in mind the FHL tendons will be the most important structure. You have to find them first in order to prevent injury to the neurovascular bundle. And the last portal is accessory posterolateral portal. Usually we prefer this portal if you perform a PASTA posterior arthroscopic subtalar arthrodesis. You may require to use an accessory portal as shown on the right hand side picture. And here was how to create a posterior accessory lateral portal. The portal is 1 centimeter posteriorly to the tip of the fibula and 1 centimeter above that spot. The indication for the posterior angle arthroscopy, including intra-articular pathology such as osteochondral lesion of the talus, talar fracture, posterior malleolar fracture, loose body, ankle arthritis, and subtalar arthritis. Extra-articular pathology including osteogonums, flexor hallucis longus, tenosynovitis, and PVNS. For the applications, we use posterior angle arthroscopy to debridement or the soft tissue impingement, remove a loose fragments, and osteophyte. For the FHL pathologies, in the left-hand side corner, you can see here the FHL tendons was impinged on the fibro-osseous tunnel or FHL retinaculums. We can use a scissor to cut or release the fibro-osseous tunnel, as shown on the lower bottom pictures. For the osteochondral lesion of the talus, which is difficult to access by the posterolateral approach, we can use posterior angle arthroscopy to debridement of the unstable cartilage rims, and we can perform a microfracture. And for osteogonums, we can remove the osteogonum or either a long straighter process. Osteogonum can be removed by a one piece as shown on the right hand side picture, or muscle in a small piece, and then we can remove through the suction. And here was the video to demonstrate how we debridement and remove the osteogonum. I usually prefer a 4mm barrel burr to debridement of the bony part of the osteogonums. And you need to be careful not injury to the FHL tendons and also the cartilage during the procedure. And here is another picture and video to show how we remove the osteogonum. And finally, here was demonstrate a posterior arthroscopic subtalar arthrodesis or PASTA, and make a posterolateral and posteromedial portals. And stress hemostat is used to create a space from the skin to the posterior parts of the talus, and the direction of the debridement should go to the fourth toe. And here was the arthroscopic viewing from the lateral and the chamfer insert through the medial. And the first important thing, we try to identify an FHL tendons, which is usually lying on the right hand side. We try to lean the blunt part to the medial side and turn the sharp edges and working to the top and the bottom and far laterally. We usually not go medially. And then we can see the osteogonum right here. In this case, the bone is very soft. We can use a chamfer to eat some of them that we can remove, and the rest of them we can remove by using a barrel burr. And for the tissue here, we can use underwater cautery to shrink down. And for the PASTA techniques, if you see the osteogonum was blocking on the entrance of the subtalar joint, you can use the barrel burr to remove the osteogonums. And then I use a 4mm chamfer to clean the cartilage on the subtalar joint. And some patients, the joint is very tight. You cannot introduce the chamfer go in deeply into the joint. You can use a trocar through the accessory portal to distract the joint. Once you gain more space, the chamfer can go in deeper, and you can clean all of the cartilage, bone cysts, and the necrotic tissue from posterior to anterior directions as shown on the video. You have to make sure that you clean all of the cartilage. In some small spot the shaver cannot access, you can use a small curette, try to clean out the remaining cartilage. And this is the surface after we remove all the cartilage. And the next step we call the surface preparation before the fusion. I use a 4mm barrel burr to create a small hole or small crater. It will increase the surface of the fusion and also the bleeding surface of the subtalar joint to promote the subtalar fusion. And here was the final arthroscopic view. In some patients, you can insert the DBM to stimulate the fusion rate. This is the technique how we insert the DBM through the posterior lateral portal. And then we insert the 2 screw, and here was the x-ray look like after the procedure. And the subtalar joints heal very well. This is a CT scan at 8 weeks from the surgery. You can see they have a bony bridge here. So thank you for your kind attention.